I think we are running just on the time, and maybe the next speaker can be invited by the chairpersons.
Yeah, should I invite?
Yes, please go
Sure.
ahead.
Yeah. So the next topic of discussion is immunosuppression in LDLT versus DDLT. Is there any difference? And the speaker is Dr. M. Srinivas Reddy, and he is director in Department of Liver Transplant and HPV Surgery, Gleneagles Global Hospital, Health City, Chennai, India. Welcome, sir.
Thank you. Can I share my slides?
Yes.
Can you see my slides?
Yeah.
Thank you. Thank you. First, I'd like to thank the course directors for inviting me for this excellent meeting. Actually, I've learned a lot about immunosuppression today from experts, and it's more than actually theory. It's the experience of each of these senior faculty that's useful for us. So the topic for my lecture was immunosuppression, DDLT versus LDLT. Is there any difference? And actually, when I first got the topic, I wasn't sure whether it's actually any different, because we've never used any different protocols for DDLT or LDLT. So I did some literature study, some literature review, and then went around asking some of my colleagues and friends as to what they do in their practice. And I think to make a long answer short, I think if you ask me, is there any difference, I would say that there's no difference. I think it's absolutely the same. The type of operation itself, whether it's living donor or deceased donor transplantation, should not affect your immunosuppression protocol or policy. However, it's not as simple as that. There are a lot of other nuances that we need to look into. And when we ask this question, is it different? I think these are the questions that we need to ask. Is the population different in the LDLT and DDLT setting? Are there actually biological differences between these two operations? Is one group at a higher risk of rejection? And is diagnosis and treatment of rejection a bigger problem in one group? So these are the things that we need to look at to decide whether a patient who's undergoing a deceased donor transplantation does he need to have a different immunosuppression protocol as compared to a living donor transplantation protocol. Now, when we look at the first question, is the recipient profile different? I think it entirely depends on where you're working. I mean, just now we were talking about how in the south, combined liver kidney usually DDLT, whereas it's in north, it can be a living donor transplantation. So it depends on where you're practicing. In India, if you look at the profile of recipients who undergo DDLT and DDLT recipients are usually older. They have lower MELD scores because that's the only reason why they have survived the long waiting period to get an organ. And they have more comorbidities because of the age. On the other hand, the LDLT recipients are younger, they are more likely to be women, they have much severe disease, they have high MELD scores, they might have coexisting organ failure, sepsis, or acute kidney injury. So when we look at a patient and decide on immunosuppression, we actually look at these factors in the patient rather than whether this patient has had a cadaveric transplantation or a living donor liver transplantation. Coming to the next question, are there actually any differences in these two operations? Are there any biological differences that can suggest that these two patients would benefit from a different immunosuppression protocol? I think there are a lot of differences. I mean, we know that there's a vast difference in the donor and graft quality between DDLT and LDLT. The DDLT donor is usually older, might have had a CVA, has been in ICU for a few days. Whereas an LDLT donor is younger, is fitter, is in the best of health, and has an excellent quality graft. In addition to that, there are a lot of difference in the timeline of events leading up to a transplantation. So in the DDLT setting, the deceased donor has had a brain death. That itself means that it's an intense cytokine release around the time of brain death, which will affect the liver. The liver is taken out and is kept at a cold temperature for a much longer period as compared to a living donor transplantation. So all these things add up to the injury to the graft at the time of reperfusion and transplantation. In the living donor setting, the liver is actually completely healthy. It might have some injury during the living donor hepatectomy itself, where the graft is being handled and being transected. It is a partial graft, so there is the regenerative process start pretty much as soon as the graft is taken out. And even though the cold ischemia time is shorter in the living donor setting, I think there is a big difference in the quality of cold ischemia between these two grafts. Most of the cold ischemia period of living donor graft is actually spent on the back table in ice with operating lights overhead and with the surgeon working on the graft. So this kind of cold ischemia is much different from what you would see in the cadaver transplant setting, where the liver is nicely packed in ice in an ice box at 4 degrees centigrade. So when we say that cold ischemia time in the LDLT is shorter, I think we need to qualify it. It's not as really the same cold ischemia as what we're talking in the DDLT setting. Now, all these factors do lead to an increase in the graft injury at the time of reperfusion. Now, there's now a lot of evidence to say that there is a lot of interconnectivity between the non-directed and the directed immune responses. And a graft which undergoes significant pre-implantation injury, whether it's because of brainstem injury or cold ischemia or due to a prolonged rewarming due to a complex reconstruction, it leads to activation of toll-like receptors in the graft, leads to a release of cytokines, leads to the infiltration of the graft by inflammatory cells, which then prime the graft for rejection. So a graft which has had more injury before implantation is more likely to be primed for rejection and is more likely to have a higher incidence of rejection. And I think the last thing that we need to look at when we're looking at these two different types of transplantation is the impact of graft regeneration. Now, any living donor graft is a partial graft, and the graft starts regenerating pretty quickly after after transplantation. And there have been studies looking at what pathways get upregulated and which pathways get downregulated in the living donor grafts as compared to deceased donor grafts. And as a general rule, the repair and regenerative processes are upregulated in the living donor graft, and the metabolic pathways are downregulated. So the living donor graft actually goes into a partial metabolic shutdown in the first few days after transplantation, as it tries to recover from the transplantation and tries to use all the resources it has to actually regenerate. This is something that is not usually present in the deceased donor graft unless it is been donor after cardiac death, when the amount of insult to the graft is much more than what it is in a normal brainstem death transplantation. So how is this reflected in clinical outcomes? Now, there have been a lot of literature looking at the risk of rejection in living donor transplants versus deceased donor transplantation, and this was the recent meta-analysis published in the AJT in 2020. And if you look at all the data, the net summary is that living donor transplants have nearly a 30% less risk of having acute rejection as compared to a deceased donor graft. This is over a meta-analysis of nearly 9,000 patients who underwent either LDLT or DDLT. Now, studies have shown a similar response in the pediatric transplantation also. So children, whether it's a male less than 25, PEL less than 25, or more than 25, the risk of rejection is much lower in the living donor grafts as compared to deceased donor grafts. Now, the question here is it related, again, like we talked about, is it due to the patient selection in these centers for living donor, and is it that the younger, fitter patients undergo living donor transplantation, or deceased donor transplantation, or the less sick patient undergo living donor transplantation? It's difficult to say. But there is one study which has also looked at the impact of the closeness of relationship between the recipient and donor and its effect on rejection. And this is a very interesting study, where they looked at 64 living donor transplants and matched each of these transplants to a deceased donor transplant, with matching them to a lot of other factors which can predict the risk of rejection. And then they stratified these living donors into 3 groups. So it's unrelated donors, related but not a sibling, and a sibling donor. And what they showed was the instance of both all rejections, biopsy-proven rejections, and the instance of severe or moderate rejections which need a pulse therapy or antibody treatment. There is no difference in these rejection rates when DDLT is compared to unrelated LDLT. Whereas living donor recipients who receive a graft from a relation or a sibling have a much lower risk of rejection. So there is an amount of genetics in play here. So the closeness of your relationship determines whether you are at a higher risk or at a lower risk of rejection. Again, what is its impact on clinical practice? Does it mean that the next transplant, LDLT, if a brother is donating, should I give them low immunosuppression? We really don't know. We really don't know because that's never been studied. And how do these immunosuppressive medications work in these patients? Is there any difference in the pharmacokinetics of the drugs? Are these drugs more effective in one transplant than the other? And as you can see, most of these drugs are metabolized in the liver. Tacrolimus, cyclosporin, MMF, all metabolized in the liver. And the pharmacokinetics do depend on both the graft volume and function. So in a graft which is working well, they are metabolized much more quickly as compared to a graft which is having early allograft dysfunction. Now, some of these patients might have associated gut dysfunction or renal dysfunction that can also affect your pharmacokinetics. And if it's in a related LDLT, if the donor and the recipient have similar P450 isomerisms, both of them are rapid metabolizers, or both of them are slow metabolizers, again, that will impact your bioavailability of tacrolimus program. But what the studies have shown is that there is no clear answer for this. This is one study which looked at compared the pharmacokinetics of tacrolimus in DDLT and LDLT. And you can see in the patients who have undergone LDLT, there's a wide range of responses to a single dose of tacrolimus. Whereas the DDLT, the responses are much more tighter because the clinical course of DDLT recipients is usually much more straightforward than the LDLT recipients. But overall, the authors found that the area under the curve, which is the amount of exposure of the drug, is about 30% higher in the living donor setting for the same dose of tacrolimus. So once again, that means that probably your 1 milligram of tacrolimus goes longer in the LDLT setting as compared to the DDLT setting. Now, another study which looked at the pharmacokinetics of mycophenolate mofetil reported the same thing, that the bioavailability of the active ingredient, which is free mycophenolic acid, is higher in the LDLT recipients as compared to the DDLT recipients. So finally, I think the main issue again here is the diagnosed rejection. Is it more difficult to diagnose rejection in the living donor setting as compared to DDLT setting? So does that mean that because you want to avoid rejection in the LDLT setting, do you need to give more immunosuppression? Now, clinically, we know that rejection has a multiple different diagnoses. It can be ischemic perfusion injury, it can be sepsis, and in the LDLT setting, it can be technical issues. It can be a venous a graft thrombosis, it can be undrained parenchyma, it can be a biliary issue, or the complicated by liver regeneration. Now, the main two modalities that we use to predict, to diagnose rejection are liver function tests and biopsies, and both of them have their problems in the living donor setting. Now, the trend of transaminases in the DDLT setting is very straightforward. So the enzymes peak for the first 48 hours, and then they start coming down slowly. But so by the end of your first week, if there is any upstroke of enzymes, you know that there's something happening. It's more likely to be rejection. In the LDLT setting, it's much more complicated because the enzyme peak is not very high. It's more of around 200, 300. And then as they come down, there is fluctuation because of competing responses of regeneration, ischemic perfusion injury, maybe low-grade rejection. So it's very difficult to pinpoint and say, okay, this is now rejection, and then we need to treat it. So we need to take a lot of other factors into account. We need to look at septic markers. We might need to do some imaging to rule out technical issues. And biopsy is not always very helpful in the living donor setting because rejection might be complicated by some cholestasis secondary regeneration or sepsis. So it's very uncommon that we get a clear cut of diagnosis of rejection in the living donor setting as compared to the DDLT setting. I think I'm running out of time, so I'll quickly go through this finish off, come to the end. So to finish off this presentation, for this presentation, I did a very unscientific survey. So I contacted 23 of my friends in different centers across the world and asked them a single question: is your protocol for immunosuppression different between LDLT and DDLT? And as you can see, most of them were centers in India, but we had some centers from the West also. And the answer was very much the same. There was no difference in protocols between LD and DDLT, any of the centers. The protocol was the same, but it was tailored to the individual patient. So if patient is older, kidney dysfunction, sepsis, so based on that, you decide what kind of immunosuppression to give, but you never base your immunosuppression based on whether it's an LDLT or a DDLT. So to conclude, I think if you look at the literature, there is some evidence to say that LDLT grafts might be having lesser rejection rates. The risk might even be lower when the donor and recipient are closely related. However, the evidence might simply be a reflection of the differences in the baseline characteristics of these patients. And in clinical practice, from what we are doing and what most of the centers seem to be doing, there is actually no difference in immunosuppression protocols between these two patients. Thank you.
Thank you for the excellent talk, Dr. Reddy.